We are live in 5, 4, 3, 2, 1. You're live, sir.
Thank you. Good morning, everybody. Welcome to our August edition of the case presentations. Today, we are going or transitioning into a little bit of a theme-based meeting. Most of our talks today are going to be about non-unions that don't behave the way that we expect them to. Also, today we will be having a little later probably a new mentor as part of the program, Dr. Hemant Sharma from Hull. I will introduce him when he joins. So we start off today's meeting with a presentation from, Dr. Hemant Sharma has joined. So Dr. Hemant Sharma is originally from Gwalior Medical College, then went to the UK, now is a leading practitioner and educator of the Elizarov method. He works in Hull in the UK. He runs a very well deformity course in Hull and also offers fellowships through Assami, India. Welcome, Hemant. I know it is a little early, quite early actually for you.
That's fine. Thank you so much.
Yeah.
Thank you for inviting.
Yeah. So as I've been discussing with you also, the idea is to get more mentors to look at the presentations and the work that is done, so that we get more discussion and varied points of view. Dr. Vasudevan will be joining us in some time. So we start off with Dr. Sumanyu, who was a fellow with me. Now Sumanyu works in Bhubaneshwar, and he is going to discuss a case of CTEV, which was untreated, then sustained an ankle fracture, and what he did to resolve that problem. Sumanyu, you can share your screen. Okay, go to full screen. Play the presentation. Yeah, you're visible. Go on.
Good morning, all. I will be presenting in an ankle fracture in a club foot and a patient with multiple contracture in upper limb and lower limb. To start with, a 34-year male has a bilateral hand and wrist and neglected club foot. Had a fall from bike around 2.5 months back when he presented to me, and he has sustained a right ankle fracture dislocation. And before that, he used to do all his activities uninterrupted without any issue, even riding bike and attending political rallies and everything. So when he came to me, initially he was treated in temporarily first in All India Institute, and then because of some issues, he was not operated there. And when I found there's a ulcer at the posterolateral aspect of the ankle joint, and there is a severe equino-varus contracture, 4-foot supination there, and also bilateral hand and wrist contracture. On the X-ray, I found the talus is completely subluxated medially, dislocated medially. On further CT scan, I found the X-ray finding was further confirmed. There's a comminuted fracture of the medial malleolus and adjacent tibial plafond. So then I thought of doing a percutaneous saclet and a lengthening and using Elizarov device for a gradual correction. And I was also thinking about whether we can do a tibiotalar and subtalar fusion, or you can do a talectomy and use a tibiocalcaneal fusion. And if at all necessary to correct supination, we can add in midfoot osteotomy. So first of all, I put on a Elizarov frame. I put on a plantar distractor and posterior distractor, and I transfixed all the MTP joint to prevent any flexing contracture there. So I distracted it gradually, and every 2 weeks he used to come for a static correction. And I found that equinus and cavus was corrected to a very great extent. The one difficulty was I was not able to ambulate him because there is a difficulty in holding on to walker frame. So then after 1.5 months of distraction, he suddenly presented with severe pain in the foot, and it was not subsiding with high dose of pain relieving medication. And also the second toe was red, tender, and there is signs of infection. And he told to remove the frame. So then I decided to remove the frame. So we removed it, and we found that equinus, cavus, and varus are very well corrected, and remaining that 4-foot supination is there and little bit of equinus is there, but no cavus is there. So this is the X-ray after removal. The calcaneus is well aligned under the tibia, and equinus and supination is there. So then I thought of using internal fixation by tibio-calcaneal fusion or a tibio-talocalcaneal fusion after doing a talectomy. This is the picture just before the fusion procedure. When I opened it laterally, I removed the fibula, and I excised the lower end of the tibia and upper end of the talus. And when I reduced it, I was able to get satisfactory reduction. So then I thought of not doing any midfoot osteotomy to correct the supination. Then post-operatively, after 7th day, the wound broke down. So then I continued dressing for about 10 days, but still there is not much improvement in the wound. So then patient told, she was from a far distance, so he told to do something so that I should not do dressing because it's very difficult to get a dress up there. So then I, under local anesthesia, I put on a small skin graft, and within 7 days it healed up uneventfully. So this is the X-ray following the surgery. Because of some CR issue, I was not able to identify there is a medial fragment was there, talus, which I should have removed it, but it got unnoticed. Then after 6 months, when he presented to me, there was no equinus, there was put as plantigrade. And on hind foot, posterior view, the heel is well aligned and little bit in valgus, and he was able to walk without much difficulty. So the only complaint he was telling, sir, I cannot walk without the footwear because it was painful. And also he is telling now the operated foot is better, but the contralateral foot is the pain has started. So this is the X-ray, the tibio-calcaneal, tibiotalar and subtalar joint is in maintaining position, and they are fused. The calcaneus are well aligned under the tibia, and the foot is plantigrade. So take-home message is severe degrees of foot and ankle deformity can be treated in 2 stages. One stage will correct the deformity to minimal amount using gradual destruction method, and then to use fixation device to keep the joints fused. And probably a midfoot osteotomy would have avoided the painful event which happened during the procedure, and probably forefoot supination would have been corrected in a better way. Thank you.
Thank you, Sumanyu. You can stop sharing your screen. So now, having done this, if you have a similar case, what are the things that you will do differently that you didn't do this time?
Sir, I'm thinking probably the pure soft tissue destruction is creating a lot of problem and patient is having pain. Probably addition of midfoot osteotomy will help in correcting the cavus and really not giving much pain to the patient, because the bone along with the tissue will be distracted.
But when you do a osteotomy also, you have this was a patient of multiple soft tissue contractures. You're still going to have issues with distraction of the soft tissue. Soft tissues are tight. So even if you do an osteotomy, they are going to undergo, meaning they are going to undergo distraction. So that pain potentially could still be there. What do you think about your position of the fusion when you put the TTC nail? Just put on share your thing again and show us that slide. Yeah, the slide above that. So this, what problem do you think that this will give or gives the patient, especially if the foot is stiff? What I'm noticing, yeah, go on.
So the forefoot, probably it is still in some degrees of supination, and also probably the midfoot joints are also probably degenerate subsequently because of hindfoot fusion.
Okay.
That may probably subsequently may cause him pain.
But what about this, your position of the heel in relation to the foot, in relation to the tibia? Normally we say whenever you're doing a fusion, you move the foot a little posterior.
Yes.
So that it becomes easier for the patient to vault over the foot, especially when it is stiff.
Yes, sir.
You know, so that in this case, you have actually elongated his forefoot by the foot going forward, and that could be one of the issues that he will face.
Yes.
What was the reason why he was not willing for surgery earlier?
Because he was telling I was able to drive, I was able to walk 10 kilometers. He was working in a supervisor in a bus depot. So he was telling I was able to do everything. So why should I get up?
Okay. Okay, you can stop sharing the screen now. Hemant.
Yeah.
This is something unique to India. You would have seen it in your, post-graduation days. I don't think you see much of it now in the UK, because people will tend to get treated more earlier. What would be your sort of thoughts on this?
So
what was done, and also if you had to treat this patient?
So a few things. Yes, you're absolutely right. The first thing what happens is that we are actually, in my initial years, we hardly got any foot. now we have a lot of asylum seekers. So a lot of population from Africa is Hull city has voluntarily taken a lot of asylum seekers. So population is increasing, and we're getting a few more feet these days. So one of the things is just sort of a technical thing is that when you cut the fibula, rather than cutting the fibula, just take a stabular reamer, smaller size, 34, 36, and just ream the fibula rather than cutting it off. Because when you ream the fibula, you collect the graft, which will take you about less than 5 minutes. And these are all pre-prepared grafts. So when you cut it and try to chop it and use the graft, then it becomes difficult. And the reason for that is that often you will find when you correct these feet and you do osteotomy, that some position is not looking very good and the contact isn't very good. And then that area where the contact is not good, you can pack it with these grafts. And if you have very good contact, you can still pack it around just sort of as a stimulus. So that's just a helpful thing and saves you time. So generally what we tend to do now is that we tend to do a lot of hindfoot correction acutely by either shortening the tibia or I haven't done any talectomy. I've done a lot in fellowship with Michael Laverick doing pediatric cases, but in adults, I haven't done any talectomies. But with osteotomies and a bit of shortening, you generally tend to get reasonable correction. Though I have to say, I never see cases as bad as you guys see. So I think it would be a little bit easier for me as well. And then whatever is remaining, so once I've aligned the hindfoot and then the midfoot, I tend to usually correct with a butt frame, because that I find a little bit easier, even with the hinges kind of thing, because it makes it a little bit easier and you get it correction much easier. So because one of the concerns, Sumanyu, I have is that, and always people do it and I always worry about it, that once you put in a frame and you put in an internal fixation, the risk of deep infection, that always worries me after the frame. So usually what I tend to do is I tend to do acute first, and even if I have to do acute and gradual together, I plan it in a way so that my internal and external fixation elements don't touch each other. So the risk of infection is reduced. Now, this could be I worry too much, or it could be I haven't done enough of these feet, whichever way. So that's what would have been my approach.
Thanks. So, and generally, so in this kind of a situation, you would tend to favor, if possible, of course, acute corrections wherever feasible.
Hindfoot, yes, hindfoot at least acute, because I find it much easier to correct because I can shorten the tibia.
Right.
And then so hindfoot and ankle corrections easier with and I'll just percutaneous tenotomy of the TA, because that causes a huge amount of problem. Now, other thing is that, which you pointed out, was that if I have any concerns, then I will also release the soft tissues at the same time prior to doing that, because I think that is the most integral part in helping you correct the deformities.
Yeah, I agree with that, because even when we are doing soft tissue distraction, I do a percutaneous release of the tendoachilles through that 3-incision method, just stab incisions, and a percutaneous release of the plantar fascia, because I don't think it makes sense to waste distraction force on a tight fibrous tissue. So once it's released, the distraction is that much easier. Dr. Vasudevan has joined us. Dr. Vasudevan, your opinion on...
I have not seen that case well.
Okay.
Only I saw the last slide.
It was a CTV neglected.
Okay.
Which was treated by external fixation, and then the patient had pain, etc. So then he kind of switched over to internal fixation. The patient demanded removal of the fixator, and he switched to internal fixation. But he had more or less a good correction with the fixator.
Right. No, because the external fixator usually, as you said, now the soft tissue are the main enemies, we must weaken our soft tissues. It's always better to weaken our enemies, so that our frame can be easier to correct it. And in adults, you have to think in terms of like joint congruity, or some of the joint may be painful. You may have to do selective fusion, or that sort of thing may be needed. It all depends upon overall the bone, the joint quality.
But even there, I believe that doing the soft tissue distraction allows you to get everything into position. Then
Yes.
for the fusion, the amount of bone you need to take out
Is much less.
is less compared to
Many of the time you may not need any fusion also.
Yeah, but if at all it's painful. One more thing I wanted to ask you was, you probably didn't see that, but Sumanyu had fixed all the toes with K wires, which were then outriggered to the frame.
Okay.
You know what I mean? Sumanyu,
Yeah.
can you show that picture? Your initial sort of close-up of the frame which you had. Yeah, this one.
Okay.
I don't often do that. I do get when I'm correcting these, I do get a little bit of contracture.
That that get corrected automatically.
That corrects with stretching. So that's what I wanted to know. I know there are folks who advocate pinning the toes into a straight position before doing the correction. But do you do that?
No, I don't do. I just keep that rod there, and from the rod I put a rubber band to the toe so that it will be dynamically pulling it up.
All right.
That's the maximum I do it.
But still, they do get some contracture, right?
It gets corrected later on.
It's corrected later on. Hemant, what's your thought on that?
So, what I do is, if there is any syndromic feet, and especially we tend to get Charcot-Marie foot, Charcot-Marie tooth cases, and in cases which have a progressive problem, I tend to wire, but I have to say I've wired probably 2 or 3, but generally otherwise I'll do the same way like Vasu does. And also I think if patients is local, then I'm less inclined to put it. If patient is traveling from far, then I'm more inclined to put wires because they don't get to physio that often and stretching is not that easy. Right. So syndromic and patients from outside my city, that's what I would do.
Great. Yeah. I think that Sumanyu probably works under that circumstance. He's always complaining about how, his patients are financially challenged and they come from far away. So he has to modify the standard things to a certain extent. Great. So that was a good illustration of the use of the Lizarov for difficult cases and how to get out of that particular problem. So you can stop sharing.
Why was that rod was placed at the end, intramedullary?
Patient demanded removal of the fixator.
Okay.
And then wanted something done. But yeah, the point I think you're making is you could have just given him a cast.
Yeah.
Kept him in a plantigrade position, allowed things to stiffen up in that position, and then deal with it. Yeah, I think that's a valid point, that it's not absolutely necessary to fuse him. Once they are in a straight position, if they can wear a splint for a reasonable length of time.
Yeah. Now that rod takes care of the hind foot part. What about the midfoot and that part? It's not being protected by the rods.
It's not. True. So
what we do is, after getting a reasonable good correction, I do an under GA examination.
Yeah.
Replace it well, and the original wires has been applied in the bad deformed position. Then replace it to some good wires that is soft tissue balanced wires.
Yeah.
Probably that will eliminate the patient's pain and agony, and then he will tolerate it better.
True. Yeah,
Because,
generally, I mean, I don't
want
need new
to
wire.
retain the same wire again.
Yeah. Yeah, that's what I also tend to do. That is, first correct the deformity, then keep the fixator itself in a holding mode for a little while. Then a little more while, take off the fixator and keep it in a cast. And then finally, on a long-term basis, use a splint. But here, I guess the patient was from far away and wanted that frame removed. So his hands were tied to a certain extent. All right. Thank you. So the next case is now the next, all the other cases are non-unions which failed to unite or didn't behave the way that we expected them to. So Ankit, who was my fellow earlier, now works at Udaipur, has a case of a femur non-union, which gave him trouble. Ankit, you can share your screen. So this is a new classification. Delayed union, very delayed union, and some of us will have very, very delayed union also. Go on, Ankit.
Yeah. Good morning, sir. Good morning, everyone. So this is the case of pathological fracture of shaft femur, which was united, but united very late. So the presentation was in November 2016. The patient was a 56-year-old male, a very hefty fellow, over 120 kg weight. His original injury was 18 years ago. It was a polytrauma kind of accident with the right femur fracture, tibia fracture, and over the years, the patient has underwent multiple surgeries, which included external fixation, internal fixations, debridement, slabs, bone grafting. The last surgery was almost 5 years back. The patient has had on and off first discharge from the right mid-thigh since last 2 to 3 years, but he was able to walk for his daily activities. He had a short limb, stiff hip, knee and ankle. He had exertional pain over the hip joints or the whole limb when he used to walk for a long distance. And presently, the patient presented with a history of slip and fall at home. So this was the first X-ray showing a fracture of the pathological femur bone, obliterated canal, sclerosed ends, and the other X-ray showed an arthritic hip joint on the same side, united the distal tibia fracture, fused tibio-talar joint. So the first, I got a CT scan done showing in a bone which is depicting the old osteomyelitis with sclerosed bone, sequestrum, and obliterated canal. With this history, the size of the limb and history of long-term infections, my options were actually very limited. The main option remaining was using an external fixation as LRS and doing debridement and local antibiotic delivery system. This was the pre-op skin condition. So the surgery consisted of excising a couple of centimeters from each fragment to freshen up the bone, canal reaming, stimulant with vancomycin beads, shortening and docking, put on a LRS and did an proximal osteotomy for lengthening, and also collected an intra-op sample which showed no growth on pus culture. The patient was already 4 centimeters short before the surgery. This surgery got him another 2 centimeters short. The intra-op picture showed some patches of avascular bone fragments, loose debris, a lot of granulation, a thick fibrosed muscle and skin cover. It was very difficult to get in and do the excision and bone mobilization. Finally, got away with this, put on the LRS, also did the osteotomy. In the distal fragment, instead of 1 clamp, I put on two clamps with 5 pins so as to provide a better hold in this heavyweight patient. The post-op picture in the lateral view showed some translation, but overall it was sort of okay to just continue for distraction and wait for the union. So this was the immediate post-op picture. Because of shortening, there was some duskiness and edema of the limb, but the wound healed and eventually. At 2 months of distraction, the original length of the femur was regained. The patient was still 4 centimeters short. But on the X-ray, there was apparent visible varus angulation, medial translation of the distal fragment. The pin started to show bending. The alignment at the docking side was reduced, and there was no signs of callus or progress of union at 2 months. So at this point, the distraction was stopped and waited for another 4 months. At the 3rd month, I did a bone grafting at the docking site. This angulation and the translation was accepted as such. One of the pins in the proximal fragment bent, so it was replaced. At the time of bone grafting, did some freshening up of the areas to improve the contact. So there was definite radiological progress as well as clinical progress. The patient was starting to bear weight, and for almost 6 to 8 weeks, there was no pulse discharge. And fast forward to 1.5 years, this X-ray was taken without the rail. So in the last 10 to 12 months, the patient had been walking with weight bearing, which was gradually increased, and the fixator was also dynamized. There was no pain on weight bearing. He was able to walk without any support. But the pus continued from the fracture site, and the pin, which was just proximal to it, on and off basis. Patient used to take oral antibiotics when the pus discharge was increased. Before frame removal, I got a CT scan done, which was on almost most of the cuts. It showed definite discontinuity of the cortex. There was not any definitive signs of union. But it was almost 1.5 years post fixation. The patient was starting to get restless and wanted a frame removal. So the frame was removed at 1.5 years. I had done the dynamization. I had also asked the patient to walk without the rail, just on the clamp for 1 day. And but as soon as the frame was removed, on the next day the patient had pain, was not able to walk, and other forms of internal or external fixation was ruled out because nailing, plating were not possible here because of long-standing infection, and any kind of bracing was also impractical because of the large size of the thigh. So the patient presented again after 1 week with pain, unable to bear weight. So again, the problem was the same problem of fracture femur with a pathological bone and a long history of infection. Thought of other options, but frankly, I could not think of any. Discussed with my seniors and other friends, but could not think of any other option better suited than a LRS. So did the same surgery again, freshened up the bone, put on a 2-clamp LRS this time in compression mode only. Again took a pus culture from the bone, deep pus culture, but it was negative. But continued antibiotics empirically for 8 weeks this time. 4 months after the second LRS, this was a picture which was showing increase in the lysis around the fracture site. All the time, before the surgery and after each surgery, the inflammatory markers were always within normal limits. So there was no method to gauge or estimate if there is increase in the local inflammation or infection. So the X-rays were showing an increase in the lysis. There was increase in the pus discharge from the non-union side and the pins around it. The patient continued to walk. He was feeling better in his walking and walked with more confidence. So again, 1.5 years after second LRS, the frequency of the pus discharge from the infection side had reduced. He was able to walk without any support for the last 6 months. There was no complaint of pain. Only complaint was slight trickling of the pus from the pin sides. 2 years down the line, another CT scan was done. The patient was walking comfortably. The frame was completely dynamized. This CT scan again showed in some slides there was definitely a discontinuity of the cortex, but I could say that at least 2 of the 4 cortices were continuous and continued same for the 3 more months with weight bearing and walking. So in November last year, the X-rays shows much improvement. There was most definitely some union there. CT scan also showed improvement in the union, and the frame was removed. This LRS was removed after 2.5 years. The first one took 1.5 years. So total, this is the picture 4 years after the first surgery. And in the next follow-up, the bone is consolidating, remodeling, and there is no sign of lysis or reappearance of the fracture line. Patient is clinically very well. Only problem is the trickling of the pus, which is still continuing even after 7-8 months of the frame removal. He is just putting on a adhesive bandage there, continuing his all daily activities, able to walk for his household activities as well as drive a car. His knee range is 0 to 30 degree, which was his pre-op status. He is still 4 centimeters short, which was his pre-op status. And this is how the patient is walking now without it. This was the X-ray done a couple of days back. So showing a good consolidation of the regenerate as well as the fracture. So no complaint of no complaints related to fracture. Just this, the pus is starting to trickle down from the one of the posterior sinus. The lesson which I have learned and I would want to convey is the most important thing I learned is being true to your patient. This was a very experienced fellow in case of orthopedic surgery. He had almost 20 years of experience with multiple doctors. So at every follow-up, I used to tell him that this is not going right and this is taking time and we may need a second opinion or a second surgery or third surgery as well. He had consulted the doctors as well, but I think because he was always given the true information, he was never agitated or worried about the results. It took time. Second thing, which is my question to the mentors is, in such cases, long-standing infections, most of the time we don't get a culture or it is resistant to all the antibiotics. Then how can we monitor the resolution of the infection or how to progress in these cases? If I were to do this case again, I think I would do the same. I don't think there would be any option other than LRS because laser would not fit his thigh. I would just do a stepwise surgery this time. Instead of doing the osteotomy for landing in the same sitting, I would do it in the second stage. But overall, I think I would do the same steps again. So that's all from my side. Thank you, sir. Thank you, everyone.
Excellent case. So just incidentally, today morning, my friend Sudhir Warrior, who's a big name hand surgeon here, most of you all know him, sent me a WhatsApp message which says, it's all too easy to believe that we and our operations are far more effective than we and they are. So this is a quote from Seth Leopold, who's a joint replacement surgeon in the CORR. And I think what has happened here and happens has happened to all of us, I'm sure, is that finally nature decided to allow us to win. You know, you do this, you do that, and nothing happens. Hemant, all yours.
So I think, Ankit, I have to agree. It's a very difficult case in any circumstances, and I think there are a number of things. I think so. I think being truthful to the patient, I think, is probably the most critical bit that you need to tell patient upfront that what you're going to do and what is the results and likely complications, and particularly the difficulties for patient and the family because. They may not be able to go to their job, earn their living, supporting the family, and so there is a lot of issues as such for the treatments like this. And I think overall, I think if we look at it, anything, then I always look at it in sort of dividing into two ways. One is the principles, and one is a desired results. And as Mangal has quoted Sudhir this morning, just now, very well. And I think, so in principles, I think what you did was right. You stabilized, you took care of the infection. And now the other thing is, so and the stable fixation along with taking care of infection are probably two most important things, and rest is all up to the nature that or individual body, whether they heal bone or not. It's such a complex case that I wouldn't have done a two-stage, both the things at the same sitting, as you mentioned, after experience. And the reason for that is the life is difficult enough for to heal that bone. And lengthening is an issue which can be easily compensated. And one of my friends, you might have heard of Simon Royston from Sheffield, he always says, nobody has died of a heel or of a shoelace, right? And principally, if you, because you're trying to do too much in one go, it probably for the patient, it was for patient benefit, but it made your life very difficult. So just healing the bone first, eliminating the infection was hard enough, and doing that and then subsequently looking at lengthening would have been easier. And sometimes in such cases, you can even lengthen the tibia. You do not have to lengthen the femur. So his knees were at different level before. You just tell him they should be at a different level, your leg would be equal. So tibia, you can easily lengthen from a different side, which is uninfected from the metaphyseal bone with a simple fixator. So that would have been much simpler for you. The other thing is that is about infection. So infection is a big enigma, and I think we look at it very, very differently. So one is acute sort of continuous infection, pouring pus, sinus. That's a slightly different thing. Once infection is settled, the chronic infection doesn't give you any inflammatory raised markers, nothing apart from the clinical. Pin site oozing is quite common, so that I wouldn't worry particularly in the femur. So monitoring infection, if patient is clinically fine, I wouldn't worry too much. We have changed our practice in infections in a number of ways. We used to give 2 weeks of IV and 4 weeks of oral, and if you have polymicrobial and very difficult bugs, then sometimes 3 months. Now, since the OVIVA trial, which Oxford did in the short and long-term IV infections, and they found that short-term IV is as good as long-term IVs. So now we give 1 week of IV and 5 weeks of oral in these cases. And the results have been quite same. Then I think the other thing is the stimulant which you use for Tobra and vancomycin, which will cover all your sort of quite widespread, wide spectrum, and will cover all your bugs. The question of it grows anything or not, it depends on a number of things. Our sampling technique, and also histology is very useful. And if you look at that paper from Oxford, which said that 5 polymorphs in every high power field, if it's more than 5, then even with the negative culture, the infection is more or less proven in the study. It is this some further validation by the number of people who mentioned on the histology. So that's other thing you can look at in future for your patients. Culture, if you look at it, about 40% of these patients have negative cultures. And it's partly because the type of bug, which is slow growing, our culture methods in the lab, how we transport, how we take the sample. So all of things vary. So I think negative culture doesn't always mean infection. If you're clinically worried, then I will still treat it as infection, full stop. The other way to look at it is that can you do something simpler? So the idea comes in that, can you nail this patient? So it is, I probably would have nailed it. And what I would have done it, debridement like you did, stimulant the whole canal with Tobra and Wank. And if Tobra is expensive, then gentamicin is equally good. But they just remember that with gentamicin, the bead setting very, very quickly. So you have to put a bit more saline in it. And then I probably would have nailed it. The advantage of nailing is it's very, very easy for the patient. It will give you good stability, a decent size nail. And the advantage is that if you have an infection, which you can have, so in that case, you can exchange nail. And I mean, it sounds a bit silly, but even exchange nail or two exchange nails would have done the same thing, but it would have been much, much easier for the patient. And the reason for that is femoral frames, either LRS, Ilizarov is very difficult, even LRS is very hard. So it's very difficult for patient. And what you tend to end up losing the knee flexion. Another thing that was, when I saw the video of patient walking, I wasn't sure how much knee flexion patient has got. And if you end up with the knee stiffness, then a large part of your results are compromised because patient is functionally compromised. So these are my thoughts, and as something more come in, I'll pitch in. Thanks.
So that's straight away one more way of looking at it. What Hemant said in the end is, can you use a nail? Which, if we dissect it, is a very, very reasonable approach for a couple of reasons. One, this osteomyelitis is a kind of diffuse osteomyelitis, in the sense it's everywhere in the bone. I probably would do a PET CT to kind of identify. And I have, some of you all will remember, Divya, what is the name of that gentleman from UP?
Akhilesh.
No, Mishra. So this gentleman had, I think we did just like what Hemant said, we revised his antibiotic nail, I think 3 times, if I'm not mistaken. He finally healed. But one of the sort of advantages was that he was mobile, and he was nowhere near as big as this patient. I mean, he was a thin, but this was an infection which was, a bad infection, which would keep, despite debridement, this and that, he would still have some discharge. So it was growling all the time. So that certainly, I think, is one option, to use an antibiotic nail and then go ahead and then, depending on what's required, revise it. Second thing, what he pointed out was focusing on one problem at a time, which is a principle we use so often in congenital pseudarthrosis. Getting that united itself is such a big deal that we don't want to add the additional issues of lengthening. And if you just share your screen, Ankit, I want to point out a few things technically. We will hear from Vasu in the end, because I know that Vasu doesn't like the LRS at all. So he will give us either some non-Ilizarov or some Ilizarov solution. But further down. Show me the one which is there after removal. There's a lateral after removal. Yeah, okay. Now, if you look at, put this full screen. If you look at the scatter of the pinholes, you see, they are not absolutely in one straight line. And the most likely reason for this one is the stiff soft tissues. So I will take extra care to kind of, incise right to the depth and reach the bone before I put my sleeves in. The second could be that, okay, appropriate templates were not used, but I think in your case, you would have used the templates. But even then, with the templates, the drill bits, if your sleeve is not going right in, again, this guy was a large size. So it's very likely that your sleeve was not touching the bone. So the drill bits do tend to deviate a little and skive a little off bone. In itself, the LRS is a relatively unstable frame, though it's good for, tibia, but large patient, very stiff soft tissues. I've had this constantly happening with me where I do a lengthening and the pins start bending. Now, and that's because of the relative play in between the rail and the clamp. Now, what Pitker has is they call it the alpha. I think it's something like the MRS fixator, which is much more stable than the LRS. So I've moved completely to that. I hardly would use an LRS now for the femur. However, one area of weakness still remains is the pins. So when you've got a large soft tissue envelope, then your pins become very long, and then the cantilever effect plays in. So the pins can't be that stiff. So I think all of those things, but in spite of everything that I have said, yes, I have faced cases like this which behave, poorly. One more additional thing, which advantage we have in Mumbai, and Hemant definitely has in Hull, is that we can consult with infectious disease people. But I don't think that's a big disadvantage, in the sense, once you start doing X number of these cases, you can always get a sort of partnership with some physician, even if they are not, specifically qualified infectious disease people who have an interest in infectious disease, and then work together for most of your cases. So now I think I don't think about the antibiotic at all. It's always ask our ID person what is to be given, how much, for how long, etc. And then you can discuss it with them. But usually that comes, the advice comes from them, which I'm sure that's the way that Hemant also operates. So Vasu.
Yeah, Ankit,
Your thoughts finally.
Please keep that same X-ray which is shown there. I mean that slide in full mode. The X-ray, same this thing. Keep it full screen. Yeah. The point which Mangal said, you can see that I've seen from the. I do LRS occasionally. I'm not against LRS. But the problem here is, as Mangal said, because of soft tissue, what I do is I pass a K-wire first. And you confirm everything is fine. And you do a cannulated little bit on top of it. Then you can make it perfect. Even with the sleeve, sometimes, as Mangal said, it can slip. So this will create a force which is unnecessary. It will go here. It won't compress in the center. And the next thing is, you can see the mechanical axis, the proximal mechanical axis and the distal axis. There's a varus. The femur is a bone where your anatomical axis and mechanical axis are different. So the mechanical axis mostly goes off the bone. So whenever the patient loads, it breaks it. So the frame must be very, very strong. So I would like to translate this. I as Hemant said, I won't do the corticotomy on day 1. And I will translate the distal fragment laterally so as to get this axis. So, and aim for a little bit of valgus. The patient is having a Trendelenburg gait. They are saying the hip is weak. So you can see that every time he moves, his torso is moving to the opposite side. So the mechanical axis again shifts to more medially. Okay, whenever the opposite pelvis drops, his center point, the loading goes still more medially. So every time he puts the load, the stress is on the non-union side. Your pins are not able to protect it. The pins are placed eccentrically. So you are dealing with a mechanical problem here rather than a biological one. And if your pin is perfect, then I would like to do a distraction on this thing in about 3 months' time. that was the time where it was showing some sort of healing. I would like to distract it and compress it. So instead of keeping it for two years and all, I don't think I'll keep it for 2 years for this thing. This you are actually allowing more. You help the nature to heal. And the placement of the pin is very, very critical in LR. And do step by step. Finish one side, finish on the other side. And because this is a little critical one.
Great. So,
Mangal, sorry, just can I make one more point?
Sure.
With the lengthening nails, one thing we have realized is that the soft tissue becomes a problem. So whenever we do a femoral lengthening, these days we tend to release TFL prophylactically at the beginning because it causes huge amount of problem. So that is another thing to consider, that any soft tissue which might cause problem in lengthening, that should be dealt either at the time of surgery or during the surgery if patient is having too many problems.
I agree. TFL and sometimes even the adductor origin at
Yeah.
pubis do a generous release. Great. So that was, Ankit, the basic point is, even if one of us three so-called experts, mentors had done it, it's quite likely that we also would have struggled, right? So it's not that you've done a poor job, but these are the other things that one can think of. Oftentimes one is infection. So one is focused on, I'm not going to do internal fixation. So we can think a little differently the next time, that, okay, what's the worst thing that will happen if you ream it out and put in a nail? Is you will have to take out that nail. But as you pointed out, if you're discussing things with the patient, talking to the patient, this is something that must be part of the thought process when we think of it. There are a couple of questions on this case. Sumanyu asked Ankit's case, could we have used antibiotic coated nail? If you mean antibiotic cement nail, yes. Antibiotic coated nail, I'm not so sure how useful that is. Hemant has pointed out that that's available only for the tibia, at least over there. But antibiotic coated, cement coated nail, yes. Antibiotic coated plate. Hemant does not have access to antibiotic coated plates, but in India you have access to everything because no real certification is required. So what we do is we put antibiotic cement on a plate and slap the plate on. But Sumanyu, I think the biggest issue here was the thickness and the rigidity and the sort of fibrous nature of that soft tissue. So passing a submuscular plate would have been next to impossible, or you make a large incision. So if anything, a nail. Also, can we use BMP? I don't think so. Here, the issue was not really so much related to the, meaning it's too many things together. So I don't think using a BMP here gives you any advantage. And anyway, a person like you in Bhubaneshwar, treating tribals coming from far away, BMP should not be in your dictionary at all. Just kidding, okay? Yeah.
Sorry, go on. I'll after you.
Go on.
No, I was just about to say that Synthes make antibiotic coated nail, which they actually commercially coat the tibial nail, eat and protect nail. But apart from that, commercially nothing is available. And the technique we use putting on cement and those kind of things to learn all the time. Yeah.
Vikram asks, is it advisable to lengthen the femur along the mechanical or anatomic axis? I would say always along the anatomic axis, because if you put the LRS, at least, if you're using an Elizarov, that's a different matter. But if you put the LRS along the mechanical axis, the cantilever becomes too far away from the knee. So the so-called theoretical downside of lengthening along the anatomic axis is you medialize the knee. But for most lengthenings, 4, 5, 6 centimeters that we do, that's not really an issue. Divya asks a question, adding hyperbaric oxygen therapy, would that help? And the answer, as far as I'm concerned, is I don't know. That has been one of our, last ditch efforts. Nothing else is working. What else can we add to the whole equation? And we add in hyperbaric. One of those patients, after we added hyperbaric, kind of his infection did settle. But if it is, you're lucky enough to, it's available to you. There's one question from the earlier talk, Dr. Kothadia from Kolhapur, who's also a frequent user of the Elizarov, says, can we do a V osteotomy? Hemant, for that?
For the femur?
No, for the earlier case, the foot. Can we V osteotomy?
I mean, I have to look at the scans, but I mean, I have to say, V osteotomies are extremely difficult and manage with the frame. I suspect the deformities which were shown us, I suspect you can, but I really can't say without looking at the X-rays in the or actually patient's foot clinically without looking at some detail.
Technically, they are pretty difficult in such a deformed case, and soft tissue distraction works pretty well. So I'm not too sure that I would not be in favor of V osteotomy. I would rather do, as Vasu also said, distract soft tissue, and then whatever areas need to be fused, you can fuse them to kind of retain that position. Great. So who goes next? Pawan? Is it?
Yes, sir.
Yeah. So Pawan is going to. Pawan is currently a fellow with me. Pawan is from Hyderabad, and this is one of our many cases. This is not only one. One of our many cases who has refused. We will share over time. Where we've had trouble. And so this is one of those cases. Go on.
Sir, am I audible, sir?
You're audible and your screen is visible. Go on. Your video is not seen though. But you can.
Okay. Good morning all, I am Dr. Pawan. Today I am going to present a case of tibial non-union that refused to unite. So it's a case of 59-year-old male patient and smoker and uncontrolled diabetes. So he had a closed tibia fracture 30 years back, for which open reduction and internal fixation was done. Later on, after implant removal, he developed chronic osteomyelitis with on and off discharge. For the last, when he presented to us, he had a history of 1 year history of discharging sinus, for which debridement was done, followed by patient developed a pathological fracture, which was managed with the external fixator. So these are the clinical pictures of the patient at the time of presentation to us. So in the X-rays, we have seen the anteromedial cortical defect and unstable fracture pattern with an intact fibula. So the issues to be addressed in this patient are systemic uncontrolled diabetes, smoking, and peripheral neuropathy. So he belongs to cine-mediated chronic osteomyelitis classification, anatomical type A, type 4, and physiological B type of host with local and systemic compromise. And local issues to be addressed are infection, soft tissue coverage, non-union, and lengthening. So the management options we had, debridement is common. The second is fixation option, either external or internal fixation. In external fixation, we have erasure or LRS fixation with the transport, because patient is having a limb length discrepancy, would develop limb length discrepancy after debridement. And nailing option is there with the antibiotic spacer, but we had doubts that infection may flare up with the medullary implant or internal fixation, and possibility of going into a non-union or delayed union again. And LLD can be corrected with the internal fixation. So our plan was external fixator removal, fibula oblique osteotomy for lengthening, and LRS fixator application, debridement, proximal osteotomy and transport, followed by lengthening, and VAC dressing for the soft tissue coverage, followed by split screen graft, and docking and compression at the non-union side. So we applied LRS fixator, and we have done the debridement, removed all avascular clinically avascular bone fragments. So proximal osteotomy was done. These are the post-op pictures. And we applied vac dressing, serial vac dressings were done. These are the wound pictures at the serial vac dressing. So within 1 month, we were able to achieve good coverage of the bone and local soft tissue defect. So then we have done the skin grafting. So bone transport helped in shrinking the wound and improving the vascularity at the soft tissue defect. The bone transport and lengthening was done gradually. So upon docking the non-union ends, we have done the compression, but compression at the non-union site has caused stress in the transporting screws and fragment and angulation of the transported fragment. So after 4.5 months, regenerate is ossifying well, but there is a poor progress in the docker side. So we had thought of giving a bone marrow aspirate injection. So we have given bone marrow aspirate injection at the non-union site. After 7 weeks of bone marrow aspirate injection, there is some improvement at the non-union site, but healing is improving, but there is pin site infection loosening. So this fixator can't give stability for a longer duration. So we had thoughts of going for an alternate fixation option. So the fixation options we had were IM nailing, which is a load bearing implant, but technically difficult to do in this case, and there can be a chance of reinfection. And plating is the other option, which is technically easy, lesser chances of infection as a surface implant. But though it is a load sharing implant, but the transverse ends are in transverse, so there may be less stress on the plate. So we have done MIPO and iliac bone grafting. So these are the post-op pictures of the patient. So after 8 months, these are serial X-rays showing there is a progressive union at the non-union site with well-ossified regenerate. At 15 months, patient is walking comfortably without any aid, and there were no signs of infection. So these are the clinical pictures at 2 years. So at the 2 years, radiologically completely united fracture site and well-ossified regenerate with minimal limb length discrepancy. And there were no infection signs. So the learning points from this case are we have to assess and address the systemic risk factors for infection as well as non-union. Debridement is the best measure for infection eradication. External fixation is the choice in physiologically compromised host. Why we applied external fixator is it can address infection, soft tissue management, and LLD correction. And why we opted LRS in this case is there is no complex deformity and pin site care will be easy, and distraction method, it will be easy for the patient to do the distraction with single unit. And bone transport helped us improving it improved the vascularity at soft tissue defect, and it reduced the wound size. So excess compression at non-union site has caused stress on the transport segment and further angulation. So fixation losing the stability, we should think it will affect the rehabilitation of the patient, delays the union, and may lead to non-union again or delayed union. And we need to provide additional stability at the time. The bone marrow aspirate can stimulate union. Internal fixation in infected non-union with inherent stability surface implant is better than the medullary implant. So iliac cancellous graft, as you know, it is gold standard to stimulate the union.
Thank you. So that was a succinct presentation of all of the issues involved in this kind of a case, where this is the worst kind of patient to treat. You know, a smoker, diabetic, and that also uncontrolled. And they are a totally different personality, where for some reason they are not necessarily willing to take care of themselves. This doesn't come out of lack of medical care. I think this comes partly out of ignoring medical care. Vasudevan, your opinion and
Yeah, the problem which I have seen it in the LRS, Pawan, can you just go back a little bit back with the LRS? Yeah, that one. The next, the before. Yeah, right. See, earlier, I think cases which are discussed, when you try to compress the LRS, it produces a real cantilever effect, like it contacts proximally and it distracts the opposite side. It is because of over compression which is happening there. When you try to compress the non-union beyond a certain level, there's something prevent from inside, the opposite side goes out. So I think when you reduce the compression force there, probably it will align to, because originally it was much better. It got after some time, after compression only, this has developed. You just go back a little bit, maybe reduce the compression. Yeah, here it is better. You reduce, yeah, you go back a little more. Yes, the one which you shows, it's good position. So later on, it has, after distraction, you can see it is getting opened out. It happened because of the compression. You can see the rods are also bent. The pins are bent. So by that time, you can just reduce it, and maybe I would like to pull the two shank screws a little bit onto the medial side. Just loosen the clamp and pull it medially. That is the one trick which sometimes I use. In some cases, I have seen this this problem in on and off. I try to do that. And the next thing is the plating which you did on the lateral side. So now I'm even from beginning, I think I've done about 5-6 cases where I put a long plate on the medial side outside the skin and contour the plate and keep it outside, not there. I keep it here outside the skin and stainless steel plate and lock it, locking plate. And you can do a bone grafting there if you want. That's you open and finish it. Nothing is inside, and it protects. Especially here, the fibula is intact. So I would like to get this thing there. So you can see now it is perfectly aligned. Later on X-ray, you can see it has gone for a little bit of varus. So if you could keep something on the middle here, the final one, you can see it has gone for mild varus. The next X-ray, yes. So now I keep it mainly on medial side, and the screw removal is also easy. As the bone grows better, I remove one by one screw in the clinic, in the OPD itself. And patient can take bath with the frame, with the plate over there.
Let me ask you a question here before I forget it.
Yeah.
Now, if the shank pin of the fixator is getting loose because of motion, because of maybe mild infection, what prevents the screw of your plate from becoming loose?
No, but this I need maximum about 3 to 6 months. By the time I can remove it out.
Yeah, but his plate was already getting, okay, you mean just it's like a change of fixator.
Yeah.
Instead of doing a change of fixator, you put, so then why not just put on change the fixator? That also can be done.
Yeah, but this being there's no other connection there, it's simple to work with that.
Okay. All right. And finish.
And this plate need not be very, very, I mean, like titanium and all. It can be simple stainless steel being outside.
Right. Okay.
And you can use a thicker plate. A broad DC, I use a broad DC.
Okay.
Broad locking plate.
Right. So, Hemant?
Right. I think, first of all, I think it's a cracking case. Considering the uncontrolled diabetes, I think it's a fantastic result. And I think there are a few things I would, I think from the teaching perspective, I'll discuss. One is, as Pawan initially mentioned, that can we do internal fixation? And I think masculine technique has been popularized. People do it. I have to say we need to take it with a slight caution, because in the hands of propagators, I mean, in French surgeons, it works beautifully, and few other surgeons, but a lot of other surgeons have got slightly cynical view that includes me, and in my hands, it hasn't worked very well. So in upper limbs,
includes me also.
All right, well, there you go. So I think upper limb is, I have no problems. Lower limb, I'm very, very uncomfortable doing masculae. And so I think in a way, what you have done is probably, I would have put an X-fix as well. And I think because the results are so variable. Other problem with the masculae is that the graft dissolution. So you end up having a second procedure, and it's not always straightforward. I would have done slightly differently. That again, like Vasu, I'm not a great fan of LRS, and I think it's principally because I can't put it as well as Mangal can do, and I don't understand it as well with the intricacies. So I tend to use an Elizarov, and I would have used that as a fixator, and done this the same thing. I also would have had a flap at the same time, because I have the luxury of plastic surgeon. I have 2 plastic surgeons working exclusively for musculoskeletal services and for bone infections. So I have the luxury, then I can call them, and some of you may have that luxury, some of you not. So I would have done the flap, but also if there's a possibility acute shortening, and but with the previous surgery is not always possible. But if you can do acute shortening, then you can avoid the flap. That is again a possibility, and it's a difficult thing to do and easy to say. And I would also recommend that if you're doing acute shortening, have a Doppler or something. Always check the peripheral vascularity and avoid in diabetics. So in this case, I would probably wouldn't have done it, but in non-diabetics, or where patient is not old, where your vessels are not calcified, I would be keen for acute shortening. That can sometimes also help in these situations. And I think, as Vasu pointed out, I think docking site is a problem to use, and I'm not sure it is the drill holes which I make at the docking site or non-union side which does the job, or is the bone marrow does the job. I have no idea. But considering that, and again, bone grafts, there is no proven benefit of the bone graft. In a sense, if your bone is mechanically stable with a good vascular environment, enough vascularity, bone grafts does do much. I'm not too sure we use it for gap non-unions. Yes. Then I think overall, I think considering I think this is the future where we all are moving towards in limb reconstruction, where putting an X-fix and then getting the benefits of X-fix alignment and everything, and putting it in an internal fixation. And I think the only issue with this is that you need to plan this preoperatively. So you plan your pins in a way that they don't come in the way of your internal fixation. As I said in the previously, that if you can avoid touching internal and external fixation, then the risk of deep infection is reduced. Thank you.
Thank you, Hemant. So a couple of questions, and then I'll give my final sort of addition to whatever you all have said. Pradeep Kotadia from Kolhapur says, Mangal, LRS is rigid fixator for tibia as compared to Elizarov, which is dynamic fixator. Tibia is much friendly fixator. Elizarov, he means, I think Elizarov is much friendly fixator with tibia. Your opinion? Yes, Elizarov is friendlier on the tibia compared to the femur, but the LRS is also it's also a dynamic fixator. I mean, if you loosen the bolts, it's completely dynamic. I mean, you can compress it. So and you know, we've done many more good cases with the LRS than we have had problems. So one of the problems which Vasu pointed out is when you're using a unilateral fixator, how much you compress. You have to keep an eye on that. You can't just keep compressing. With the Elizarov, the wires will arc and you will get uniform compression. With the LRS, you will not get uniform compression, and you will tend to sort of tilt that fragment a little bit. So that's something to be absolutely careful about. But otherwise, I think I agree with everything that y'all have said, that in these situations, you need to kind of look at what's happening and then change accordingly. So if your fixator is not doing its job, then it's time to either change the fixator or put in a medial, as Vasu said. Or in this particular case, the reason for putting in this was this guy was diabetic. I was still not sure that he had stopped smoking. So I had no surety that this will heal in 3 months or 4 months. It could be longer. So if I could get away with something that is inside and not give me trouble, I thought that that is a better option. With regard to flap, again, I was sure that this is going to contract. The wound is going to contract. I'm going to be able to get closure. And I had full thickness skin on the proximal fragment. I had full thickness skin on the distal fragment. When both these fragments come together, I'm going to have reasonably good skin. And as you can see, the whole thing has evolved very nicely. So that was the reason for not putting in a flap. Normally we would do, I also prefer acute shortening, but here this was fibrotic. The whole soft tissue envelope was fibrotic. He's diabetic, all other kind of issues. So there, slow and steady transport, I thought, was the better option. And so I think most of those questions are answered. Sumanyu had a question. The reason for not giving local antibiotic delivery was that the wound was completely open. So there's no point in putting local antibiotic delivery there. It will just keep coming out. There was free efflux for whatever discharge was there. This is another thing that we use quite a lot. And this is something I learned again from Sudhir, to use foam for dressing. It has got much higher absorbency than gauze piece, and therefore for dressings we tend to use foam whenever we want a good granulation. Great. So
Good case.
yeah, Sumanyu has a last comment. He never gives up. He says bead pouch technique. But Sumanyu, if you look at the case, you will realize that continuing infection was not an issue. We took out all the infection by debridement. So if I'm not worried about infection, there is no real advantage to adding stuff like a bead pouch, etc. Infection was not the cause of his. After we've done this, we put in a plate, we've added bone graft, and nothing has happened to that. So good case, Pawan, and well presented. Now we go to my colleague Divya. Another case which was similar but slightly different cases why it gave us different reasons why it gave us trouble.
I have one question to Pawan. Pawan, where was the corticotomy is done? Your anterior approach or a medial approach? Posterior.
It's anterior.
I didn't see the scar there.
We specialize in scarless surgeries.
Okay.
It's a 10 mm thing, so hardly
Okay.
it would be visible.
Good morning, everyone. We'll see another tibia non-union that refused to unite, and then let's see finally what we had to do to get it united. So this was a 45-year-old male who had a run-over injury by bus and suffered a circumferential degloving injury and open fracture of the distal tibia. So he was initially treated in an X-fix, which was kept for 3 months, and then once his wound was okay, they had skin grafted it, and at the end of 3 months, they converted the fixator to above knee cast first, and then below knee cast. On presentation, this was the picture of circumferential skin grafted condition and a non-union at the distal tibia. So this was, the orange arrow is pointing to some attempt at healing. Biology seems to be okay. Overall, frontal plane alignment was good, but there was 22 degrees of recurvatum at the non-union. He also had, the orange arrow here is pointing to the recurvatum.
He also had this equinus, which is visible here. He was walking with the foot plantigrade, but if you can see here, the anterior talus is uncovered, and there is relative equinus between the distal fragment and at the ankle. And this equinus was leading to that recurvatum force at the non-union constantly. So the plan was to do a fibular osteotomy, put on an iliceral fixator, and since this was a stiff non-union, wanted to correct it gradually with the 6-axis device, and also add a heel ring to distract the ankle and correct the equinus. So the post-op X-rays, putting on the frame and the fibular osteotomy. I'll put on the hexapod to correct the recurvatum at the non-union. So first we distracted it, then corrected the angulation, and simultaneously started with the distraction at the ankle. So that's the distraction at the non-union, and then converted to straight rods. The thought process here was because it's a stiff non-union and some healing is seen, we treat it as a hypertrophic non-union with distraction. There should be regenerate formation at the non-union, and ankle distraction then continued. And at the end of 2 months, that's the comparative picture for the ankle distraction, and then we repositioned it under anesthesia to a plantigrade position and maintained it in that, and allowed weight bearing. Now, for the weight bearing, this heel ring constantly was giving him trouble. So we pulled it on for some time. And at 2 months, the regenerate was forming, but still there was a little bit of a empty area in the center. So we went ahead and did a percutaneous installation of GNX, which is a bone graft substitute. The orange arrow is pointing to that GNX. And at 4 months, seems okay. Some progress in healing, but not very convincing. But since weight bearing was getting hampered, we took out the heel ring and allowed him to continue with the weight bearing and see if things improve with that. But the equinus was returning. That was his gait at that time. Stiff ankle, not really getting any further dorsiflexion. So this was constantly putting some recurvatum stress again at the non-union. So at 6 months, we checked it under Shyam, and there was mobility at the site. So we did acutely compress under the Shyam. But since it was already in contact, again, just like what we saw in the previous case, the fragment started tilting. So now we have, earlier the frontal alignment was good. Now we have created some valgus. And we added exogen for whatever it's worth, the low intensity pulse ultrasound. But at 3 weeks, again, questionable healing, valgus, and the recurvatum reappeared. Equinus is worsening. So at that point, then we decided, okay, let's test it. And we left the distal rods loose for 48 hours. Initially walked well for a day, and then on second day he presented no pain, but he presented with a deformity. So now it's drifted further into valgus, some amount of recurvatum. So we put on the hexapod again because the pins and the rest of the fixator was holding well. So again, distracted and repositioned it and realigned. No further compression added this time to prevent that tilting. So now it's back in position, converted to straight rods and allowed him weight bearing again. We were allowing him to stretch the equinus using floaters and straps, but he would not keep them on all the time. So at this point, probably compression is not enough, though it's all realigned well. And then at 15 months, again, some points it's healing, not fracture lines still visible. And we took out the fixator and put him in a cast, followed by a brace. But over time, over a period of 8 months, he's drifted further into valgus, and the recurvatum has increased back to the same position, but now we have added valgus as another component from where we started. So around at 3 years now, that's the recurvatum on the left side and the equinus on the right side, which is the relative position of the foot to the distal fragment. So with this overlapped view of the clinical pic, the foot is plantigrade, but you don't really make out the equinus and recurvatum clinically. So now he has all problems. Valgus, recurvatum, the equinus continues. Now there's LLD as well. Initially he was around 1.2. Now he's around 2.5. And poor soft tissue cover, the deformities come back, biology questionable. So what next? Communication here was the key, constantly telling him of what issues are being faced and how best we can tackle it. So now this time we wanted to go all in and tackle everything. So for the non-union, we decided that we'll excise those ends, make the ends transverse, do central reaming, open the canal, do acute docking, temporarily fix the distal fragment with the transcalcaneal stand-in pin. Compression at the docking site will be aided now with excision of the fibula because of all that fibrotic tissue. Didn't want to take any chance with the oblique fibular osteotomy, lest it doesn't allow enough compression at the docking site and causes further angulation. For the biology, add in iliac crest graft, not only around the non-union site, but also in the interosseous space to get a cross union between the tibia and the fibula. Correct the equinus with the ortho SUV this time, and add lengthening because now we will be doing excising more bone and correct the LLD as well. So the oval arrows, ovals on the left picture are showing the excised fibular ends. The bone ends have been made transverse. The picture here is showing the transcalcaneal pin, putting the fragments, holding the fragments while we put on the frame. And this is the bone graft which is being added, punched in at the, to get that cross union between the tibia fibula, and the proximal osteotomy for lengthening. Zoomed in view of showing the orange arrow showing the bone graft. And ortho SUV was added later to correct the equinus, which was then gradually this ankle was distracted and brought back into repositioned into the neutral. This time we intended to keep the heel ring for more time, and the heel ring was then thus placed a little so that we could allow him weight bearing on the foot. So LLD sorted at 2 months of distraction, showing good contact at the docking site, and then continues to go on to healing uneventfully at 8 months. But we wanted to be doubly sure. In the interim, at around 5 to 6 months, we have taken out the heel ring because then he was this was well on its way to healing. So did a CT scan to confirm the healing at the docking site, and from then just kept the fixator on for ample precaution and let the regenerate solidify. At 10 months, everything's healed well, and the fixator functionally, there was some range at the ankle, and the fixator is removed and we protected in a slab initially and then gave him a brace. So 2.5 years, it's all well. Shows ankle movement, but there is an osteophyte at the anterior aspect of the talus, which is preventing this further dorsiflexion. Though he is neutral to plantigrade and neutral to the overall axis, but if we consider the distal fragment again, there is a slight equinus still remaining. He continues to do well, no issues from then on. Showing just a comparative video. That's the left side is before the second surgery and protected in the brace, and now the right side is the recent gait. So a lot of learning points here. The distal tibia non-union, not only generally when we talk of alignment, we in tibia especially, we tend to say that sagittal alignment is not so important, but here the sagittal alignment was the key. So correcting that along with any stiff ankle deformities prevents any deforming force at the non-union. For the biology, the circumferential degloving had definitely some poor healing potential. We did get foxed with that extra bone which was forming. We treated it as a stiff non-union initially, that it would respond to distraction and regenerate should form, but it didn't really happen. So adding bone graft substitutes or any adjuncts like lipus really doesn't really work if there are other contributory factors. So ileal graft there is a gold standard. The message we want to also give here is avoid procrastination. When things are not going as per plan, sit back, think, go through everything again, discuss amongst colleagues, find out what the real issues are and tackle it head on in time, and change your strategy accordingly. Stiff non-union, yes, distraction works to form regenerate, but now we tend to give it around 8 weeks to show itself that yes, is it well on its way to healing or not. If we find the healing is inadequate, then we will go in and bone graft the gap. Cross union in distal tibia non-unions, just like in CPTs, between the tibia and fibula, helps to increase the cross section of healing. And throughout this, communication was the key to take the patient through the rough waters, because it's a very long process, difficult situation as it is, suffering from the initial injury and then having had to go through all this process again. So the communication here was the key to keep the patients level-headed. Thank you for the patience.
Thank you. So this was more than a non-union that refused to unite. I think there were, as Divya pointed out in the end, a lot of learning points in terms of things that we could have done better and probably a little earlier. I still don't tend to open up these fractures if I have a sense that it will respond to distraction. But if it doesn't, then I think making the ends transverse, and I believe that the reaming that we do, opening up the medullary canal on both sides, probably has a role to play, so that you have improved the vascularity or the biology of that healing area to the maximum. So Vasu?
Yeah. There's a lot of teaching, I mean, learning points here, especially in such fractures. The ankle equinus is our enemy. As rightly mentioned by Divya, ankle equinus is well compensated by recurvatum at the non-union side. So now, how do you assess the ankle that the equinus? So what I do is I do the distal mechanical axis of the tibia in the lateral and draw a mid-diaphyseal line of the calcaneum. The calcaneum has a short diaphysis. So these two lines I draw, and normally we must get 120 degrees. So if it is less than that, that's an equinus. When there is an equinus, the mechanical axis in the lateral plane is actually going from the first metatarsal head to the hip joint, not from the ankle up. Normally it goes from the ankle joint up. So when there is an equinus, the equinus deformity, his mechanical axis will be going from the first metatarsal head directly to the hip joint. So it is far away anterior. So that force will tend to deform the fracture, non-union side. That's what exactly happening here. So while distracting it, the ankle joint, I keep the ankle hinges and little bit anterior like you do in a CTV. I keep the hinges there and distract posteriorly with the additional 4-foot frame. So I take it because that is the major enemy for us, not the non-union side. It's the enemy is the equinus. So you have to seriously correct that part first. So the deformity part is the non-union part is only, to me, it is secondary. The main thing is this. And if at all we are accepting the equinus, I would like to give him a high heel chapel for at least 2-3 years. So you accept that equinus, so that there is no deforming force onto the non-union side. You increase the heel, the mechanical axis shifts from the heel. So that way, so it's a different way of learning. Otherwise, it's an excellent case. Yes, Mangal.
I agree. So we recognize the equinus as the problem.
Yeah.
I think the issue that was that we should have treated it more comprehensively. We thought that just distracting the ankle and then repositioning, we did get it straight, but it was not probably enough. So a combination of a little bit of equinus, a combination of a little bit of poor healing, a combination, all of those things then came together and ensured that it doesn't heal.
I aim for at least 15 to 20 degrees of dorsiflexion in these cases.
Yeah. So that is what the word that Divya used, that the equinus needs to be treated aggressively and not by half measures. So what was done just distracting on the heel ring was probably a half measure. Yogesh has a question which is relevant to what you are saying, which you can answer, and then we'll go to Hemant. Any criteria to decide that distraction at stiff non-union site will help in healing? So how do you decide that, okay, this guy I will do just a distraction, or this guy I will open up? Vasu?
No, that's a clinical judgment. If the fibula, I break the fibula and clinically judge it. So most of the time, it's a mechanical failure, then it results in a hypertrophic non-union.
Yeah. So if it is not very much mobile, then it is reasonable to assume that this may respond to distraction.
But only after cutting the fibula out.
Correct. After the fibula has been cut. So only you're testing the tibia. And in some cases, like in this one, you may go wrong. So you got to keep monitoring it. Hemant, your thoughts?
So I quite agree to Vasu and you about the stiffness, hypertrophic and stiff non-union. And I think after it is a clinical judgment completely. And despite that, we can get things wrong at times. I mean, in this case, if you look at it, it looked to have hypertrophic non-union. And I think overall, it's a cracking case because in the sense is that there are so many things to learn in terms of the equinus and mechanical access and how we sort of overall approach stiff non-union. And so I think from that point of view, the few comments, the first one is that if you having
Just one sec. Divya, one sec. Divya, you can stop sharing the screen. Unless he has something to show, then we'll do it again.
So
everybody comes on the screen.
Yes. So in the sense that I would have done exactly the same in terms of distraction and, but what I would have done it that when I'm not getting any regenerate, one of the things I would try is the concertina, or sometimes actually even bone graft these, because I'm not a great fan of bone grafting because I don't think it does as much as we think it does. But in cases like this, because I think it looked at a stiff non-union, but overall bony contact wasn't enough. And therefore the biological environment wasn't enough, and there's no way to know about it. And therefore, in these cases, I would try concertina, and if I in the distraction I find that there is a lot of gap and the bony contact is small, I probably would have bone grafted earlier, because then I would treat it as a gap non-union. I wanted to ask you that why did you use calcium phosphate as a sort of gap filling measure, because it is only in scaffold, and unless there is a enhanced biological activity, the incorporation would be quite slower as compared to the bone graft, because GeneX is principally a filler and support, and it's got some mechanical stability. And I think the rest of the points has been made quite well about the equinus, because I think that needs to be treated very, very aggressively. And I think overall the game plan was good, but we all have the cases where sometimes it doesn't work. And then the last point is about exogen. Again, there is no suggestion, or there are some studies which suggest in the acute fractures, but I'm not a great fan of it. I usually use it so that I can buy some time and patients feel that something is being done, then I'm actually believing in it, and I give it for 3 months before moving any forward.
Yeah, absolutely. I agree with the exogen actually was put with the idea. This patient was a relatively high profile in the sense that one of his relatives was a big time surgeon in Ahmedabad. So the relationship was three-way: surgeon, patient, and relative. So that sometimes becomes a little complicated. So when the suggestion was made that, okay, why, somebody would have told him that, oh, you can try exogen. Can you use exogen? Yes, you can use it. We can try it. Nothing, no harm in trying it. So otherwise, as a general rule, I think here it was pushed more with the idea of, by them, can we avoid some more surgery? And which is what the point I think Divya made, that avoid procrastination. If in your gut you feel that yes, surgery is going to be required, then go ahead and discuss all the options and do it, which we did actually, because that 2-year 3-year gap was a matter of patient carrying on in terms of, okay, I'm scared of surgery, I'm carrying on kind of thing, which ultimately then didn't work. So then he finally agreed for surgery. So thank you, Divya. Good case, and all the learning points very nicely sort of underlined and enumerated. And now we'll all can feel a little better, because Vasu will also show us a case which
Mangal, sorry, can I ask a question to Vasu before you
sure.
sort of go to next one? Vasu, I quite like your idea of equinus and I think the weight bearing, but if you correct the deformity at the non-union side and correct the equinus, won't the axis shift back to where it should be?
It will shift back.
That's what he said. So you, if you don't take care of the equinus, then you will.
Okay, sorry, I misunderstood.
He said you have to correct both the deformity at the recurvatum as well as the equinus. If you don't, then which I have done a couple of times, is you keep the foot in equinus by using a heel raise. So still the equinus is not imparting a recurvatum force at the non-union side.
We can accept
sorry, I didn't hear properly.
Yeah.
Sorry, I didn't hear properly.
Okay. So Vasu, all yours.
Yeah. Is it visible? Hello?
Yes, sir.
Yeah.
Good.
So sometimes you feel now some non-union talking to you like, I don't want to heal. Whatever you do it, I don't like. So this sometimes happens. I'm showing an old case where this patient came to me with a 24-year-old lady, 2-year-long story, grade 3 compound fracture, more than 15 procedures, underwent microvascular procedures, microvascular fibula, external fixators, flaps, plating, Ilizaro, orthofix, and POP. And when she came to me, she had totally scarred leg with sinuses, and it's a muscular foot drop. She had lost a lot of muscles, and because of that, she's having a foot drop. So this was the situation. And you can see the whole fibula is gone. And from the opposite side, the fibula has been taken there. So the issue is how to solve. You can see the kind of the old olive wires. The olive is still remaining. The wire, they are taking it out. Now, how to manage this? She is a 25-year-old lady. So we'll go into the story of her past history. Yeah, she was a train accident victim. This was her original X-ray, a grade 3 compound fracture with a lot of bone loss and soft tissue injury. So it was managed by like biplanar external fixators. Any comments on this? You can see the pin lying there, one pin on the top, and you can see there's one more rod here. So it's a biplanar external fixator as an emergency, and followed by this type of plating. So they plated that fibula, that original fracture, this fibula, they plated it, and the plated fibula has been transferred to the tibia with a locking plate on the medial side. At the same time, they are retaining the external fixators. So probably that got infected and all the implants out, and that fibula is completely lost. And they put a cement spacer with a K-wire. So that's a cement spacer. So they removed the external fixators, and that is a spacer. So now they did a Ilizaro on her. They put the frame. They did plenty of bone graft. I think they did a fibula graft also. And look at the alignment of the tibia and fibula here. So they are very normal space. Here you can see it is very close. And overall the fixator looks good. But the next X-ray shows it is like this. So probably there was a rotational deformity here. You can see this is the proof of the rotational malalignment. And they tried, this is a long rod. And they tried to correct the rotations. Now you can see the fibular relationship and the fibular relationships are maintained. But in the process, they developed this translation. So can anybody say why this has happened? The lateral view is the same. So the reason is the tibia is always eccentric in the ring. When you rotate the rings to correct the rotation deformity, the central part of the tibia with the frame is rotating. So whereas the eccentrically placed bone gets translated. So that's what happened, it got translated. So probably that surgeon didn't have the skill to realign it properly, or he must have completely missed it. So in the process, it got malaligned. And they continued the fixator and expected the bone to heal, which it never did. So it was still remaining ununited at that point. And they gave a POP slab followed by cast. That too failed. And now they put an LRS on, orthofix on it. Put 2 rods there, 2 pins there, 2 pins below, and try to correct it. And it still remained, and I don't like to unite. Now what to do? So this was the issue. She came to me. So I was examined her in detail and finally found a planning. Like I've drawn the mechanical axis planning for whole area. And my strategy was to completely realign it. So this was how my planning was. At the non-union side, so it's a trifocal approach. At the non-union side, I would like to correct her proximal deformity. And at this area, I tried to do the deformity correction. And I did a osteotomy at this level to get the length to a reasonable extent. So at the end, I want full correction of the deformity. So I have planned where I am going to put the frame and where I am going to keep the olive wires and how I am going to put the shank screws and how I am going to get the length. So all these things has been planned well and put it on the page. You can see the appropriate placement of the olive wires. Only one ring in the middle fragment with 2 wires. The distal fragment again with 1 wire and a shank screw there. I think 2 wires and a shank. And here again you can see 1 olive wire plus along with you can add on the corticotomy at that level. And another corticotomy here, you can see it is in progress. So this is after getting correction. So you can still see here, even after the proper planning and proper placement of the wires, so I have to overcorrect the middle fragment. This is not parallel, but I have to correct it. These are all different modules. So still at the end, I got the full alignment. And this is how she was walking. And you can see the middle fragment is not aligned well, but inside the bone is aligned. You can see the soft tissue injury everywhere. She had a foot frame. That foot frame was removed later. And this was how it was progressed. And this is a 6-month follow-up X-ray. X-ray, it is completely healed. You can see how the non-union has, you cannot even, it is completely melted each other. And the lengthened area is, corticotomy said everything is healed. That's her clinical function. You can see her normal valgus there and same valgus here. And foot drop is still remaining. And that is the power of planning. Yeah. I have one more case where the thickness of the bone is creating trouble. Can I continue that, Mangal?
Yes.
Yeah. So this is another case. He came to me after 5 months of the trauma. They fully established infected non-union femur with a huge thigh due to the slipped quadriceps tendon muscles. So this was a clinical picture. The muscles quadriceps got avulsed here. It was completely displaced to that side. See the diameter of the limb. So the rings were not available. He needed 360-400 size ring, which is not available. And you can see the fully settled infection there. And a little bit history into his story. You can see the opposite hip was dysplastic forehead and arthritic. And the present problem is on the right side. You can see the pin side there. So this was his original emergency external fixator. It's a grade 3 compound fracture with quadriceps subluxation. Somebody they did the flap, the skin flap procedures and all, and an external fixators. In about 10 days time, they did a plating plus external fixator. So that external fixator is an LRS. So you can see a funny, it's not a conical pin. These pins are all different. And the gap is still there. Infection was progressing more and more. And now what to do? With this huge thigh, no rings available. So what I did was, I just used the arches, the Indian arches. I used 4 arches together, and just like a frog, it sits on the anterolateral side of the thigh with the 90-90 pins. And the whole other area is left free. I have debrided it and got an acute docking and multiple arches fixations. I have accepted the non-anatomical stable position. So interposed the fragment and stabilized it. You can see the upper ring. Yeah, and this is how it has been fixed. And you can see good callus and the final healing in 4 months' time. Thank you.
So
Yes.
multiplanar fixator with Ilizarov components, which is one more way to approach the whole issue in terms of when your thigh is too large, like what Ankit had shown. Hemant, your thoughts?
Yeah, so I think again, I mean, you guys get some really good cases. So I think one of the things I would like to emphasize here is that Vasu has so beautifully sort of presented that the effect of stability. Now, he planned that first case well. It provided the mechanical stability, and despite the atrophic looking bone ends and bad soft tissue, it healed without any bone grafting. So I think it suggests that the mechanical stability in all these situations is the primary thing, the mechanical alignment and the stability. And if you see in any of the, if you see the studies published on the atrophic non-unions, you'll find that atrophic non-unions actually doesn't exist. All the biopsy suggests there are blood vessels, but they're just delayed in the process and they don't manifest. So there is a vascularity. It may appear avascular. That is because of the way the bone is. And sometimes you have to do something, but generally the mechanical stability is the primary cause. And if you align that, it works well in and heals bone well. And this is so beautifully demonstrated in both the cases.
Right. So proper application of principles, and in one of the earlier webinars, Vasu had done a full mentor talk on what is stability and the importance of stability. So this case basically shows that even if it doesn't want to unite, often there will be reasons, and actually all the cases that we have shown today have shown that same point, that there have been reasons why it has not healed, but we have initially, at least, we have not been able to discern what are those exact reasons. And the moment you find out, okay, this is the reason, and you correct that, then it goes on to
Union.
Right. So we are a little over time. Yeah, go on.
Sorry, just one more point before. So I just wanted to that all the, especially trainees, when they look at the non-union, don't look at it in the way that can I frame it, can I plate it, can I nail it. I think the whole approach to non-union should be that what is the what is the mechanical status? If you look at the strain, what kind of stage, the high strain non-union, low strain non-union. So look at it from the totally mechanical point of view, then assess the vascularity and the patient personality, and the combination of that would be a right way to approach your non-union. And then the last thing would be to decide what implant you're going to use, because that is the least important. The most important thing is assessing the personality of non-union, personality of the patient, and then how to neutralize those factors to give you a successful outcome.
Absolutely. Very, very individualized. There is no knee-jerk reaction that infection, so fixator only, or in fixators Ilizarov only, or LRS only. You have to, in forthcoming ones also, we'll share some of these other cases, which have not done well, and what are the reasons that we found that they didn't do well.
That's the a la carte approach.
Exactly. More often than not, it's a misreading of the approach that needs.
And unfortunately, the problem now for general orthopedic surgeons are, if you have this fracture, you fix it. This one. If you have a proximal femur fracture, PFN. So that is the way it is treated. That's what youngsters are also asking us, how to do a Ilizarov for a proximal TB. So they want everything ready-made answers. So that is not possible with Ilizarov.
That doesn't exist. That doesn't exist. And that's the advantage of the Ilizarov, that you can build up stuff for, like this last case showed, no? For a particular situation, you can use various components in different ways. Obviously, we get better with experience, but you have to constantly keep thinking. Even when you are way down, or very high on the learning curve, there are still cases which will fox you, and you need to keep thinking. All right, so I will wind up now with one quick talk on what we do for stiff knees, and this today was an excellent exposition on non-unions. From next time onwards, I think I've already kind of got that plan in preparation in my mind. We will try and do something on a themed kind of thing. So say one session will be entirely related to upper limb, one session related to deformities, and have everybody present with those kind of cases, so we can get even more focused in terms of what we're doing. So, all right, stiff knee is something that will happen very often, and these cases will present to us as reconstructive orthopedic surgeons, either because they had an intra-articular fracture or they had infection around a distal end fracture. When we lengthen femurs especially, there will be a likelihood of stiffness, and also it depends to a certain extent what kind of fixator. The more you use a circular fixator, the more distal the fracture of the non-union, the higher is the chance of the knee getting stiff. Now, for the femur, generally the best way of preventing this is in the distal fragment. Use pins which are going from the posterolateral and posteromedial approach, because that's the only, to whatever extent possible, intermuscular plane, and that minimizes the restriction or the capturing of the soft tissue. So for a general application, this is the kind of fixation that we would use. Posteromedial, posterolateral Shan's pins, one on either side of the ring, and a transverse wire. When we put in the wire also, we sort of cut the soft tissues above and below to allow the fascia lata on the lateral side to have its normal excursion, proximal and lateral. But when you are doing a case like this, a distal femur non-union, which is being treated by distraction, who also has shortening. By the time you have everything aligned and lengthened, you have also pulled all the soft tissues over here in the region of the knee, which need to be very mobile. They often will have already a pre-existing stiffness, but when you do a lengthening and distraction in areas like this, you will just worsen that whole thing. I normally will give up to a year for nature to do its job. And I think 60-70% of the patients, especially if there hasn't been too much of intra-articular adhesions, etc., they will restore movement towards the end of a year. But basically, what are the structures which get affected? We need to look at intra-articular adhesions, which may be the suprapatellar pouch, also tibiofemoral adhesions, and adhesions of the gutters, where the gutters kind of get obliterated. And the other is extra-articular. So where you've got a lot of scarring along the shaft. So the intermedius, the lateralis, and the medialis will be stuck down to the shaft and not allow enough excursion. There can be bony spikes which are holding the bone and preventing excursion again. And a huge amount of damage can lead to fibrosis of the muscles, which prevents them from doing their normal lengthening. So there are two essential procedures which are described. One is a Thompson's and the other is a Jude. Most of the cases where we've got intra-articular or distal third problems, where the issues tend to be adhesions in the joint, I find that a Thompson's will work. But when there is large problem like this, where this guy had a huge gap non-union, which we treated with a bone transport. So the bone was transported right from here up to there. This took close to, I think, a year. But at the end of a year, he was healed pretty well. He had bad soft tissues to start with, and our fixator only added. This was all earlier injury, earlier problems. So with that, we had a knee that was completely stiff, and this soft tissue had been dragged all the way up. He had fibrosis over there. So his problem was not so much in the knee. His problem was the entire length of the femur. And here you can do, these diagrams are from Dr. Paley's book, where he talks about doing things stepwise, where you start distally and keep adding parts of this procedure depending on what is needed. So at the beginning of the procedure, there is, there is no flexion. This is the maximum flexion that is possible. So you start distally, and then as you keep releasing stuff, you start getting more and more flexion. And depending on the case, which component is more, has higher weightage, you will find that the flexion improves. So there is a medial and a lateral extension right up to dividing the rectus femoris tendon proximally. I've never really had to go this far. Usually going up to reflection of the entire mass of muscle from the femur has worked to give us a good amount of flexion. So this kind of thing, by this, usually you're able to get a good amount of flexion. Patients need at least 90 degrees of flexion. So here's a patient where all of the intra-articular release has been done, a medial release has been done on the other side, and the entire muscle mass has been lifted off by sharp dissection from the femur. Now, doing this, you can see obviously it's a very bloody operation, but if there is that amount of fibrosis or that kind of fibrosis, then that is what needs to be done. With that, you are able to get a good flexion. They never retain the same amount of flexion that you get on table, but pretty good flexion out of what you achieve on table is retained. So the goal when we are doing this release is, one, we should have no lag. You need the quadriceps as an anti-gravity muscle, and they should be able to get at least 90 degrees of flexion, because that's what you need to sit in things like public transport and, you know, prevent your leg from being an obstacle. So getting going right away in terms of physiotherapy, this guy is probably a couple of days. This is the same patient that you saw earlier. So getting going right couple of days after surgery is very, very important. Now, the Thompson is slightly different, where it's more focused on the distal part of the Jude sort of approach, where the most important thing, which I learned this as a medical student, as a resident from my teacher, Dr. Shahane, where he taught us and he showed us that the rectus femoris tendon is actually anatomically distinct from the intermedius, and you can if you dissect carefully, you can very clearly separate those two tendons, and I'll show you an example later. And the vastus intermedius then can be excised. So in addition to everything else that we do, release parapatellar left and right, getting this rectus femoris tendon separate is important, because the rectus femoris has got the largest amount of lengthening that is possible compared to all of the other muscles which form the quadriceps. So you incise your medial and lateral retinaculum, all the adhesions of the suprapatellar gutter, and the knees then flexed to more than 90 to release whatever tibiofemoral fibrotic bands are there. So that's the various things that need to be done. I usually go with a midline incision and then deviate it slightly laterally if I need to do any release on the lateral side. That's the kind of incision that we do. So here, the most important thing as far as I'm concerned is this careful dissection to separate or identify the plane between the rectus and the intermedius. And if you look at it carefully enough, in the most scarred of knees, you will be able to find that. And the rectus tendon is a thin tendon, and the intermedius and fibrosis all lies below it. So usually, if you notice this retractor here, I have already separated that, and this retractor goes into that interval and lifts the rectus tendon up, then allows me to separate it better proximal and distal. So now I've got a finger under that, and now here you can see this is this thin sort of band, and it seems pretty flimsy, but actually the importance of it is that if you keep this intact, you can cut almost everything else around in terms of excision of fibrous tissue and all that, and that patient will still have a good extension. He won't have an extensor lag. So it's very important to identify and separate this. Then of course you divide the lateral retinaculum. You can do a pie crusting of whatever contracted or thick fascia is there on the lateral side. There will be fibrous tissue over here. So you can see here, this is the intermedius, pretty fibrotic. So all of that fibrous tissue has been excised over here. The femur is bare, and only the rectus tendon is ending into the patella. Very clearly it can be seen here. Same here. So all that fibrous tissue has been excised. Medial side also opened up. The lateral side gutters cleared up, and the rectus has been isolated. And now we have, by this, we've got about 70, 80 degrees of flexion. Now, in a careful fashion, stabilizing that proximal tibia and holding the foot under your arm, you can apply, it's something like a manipulation, but a careful manipulation. And you can then break whatever existing adhesions are there in the tibiofemoral area and get flexion which is more than 110, 120. So this has to be done very, very carefully, stabilizing that, because if you just apply brute force, especially in patients who are osteoporotic and all, you can develop a fracture. So stabilize the entire tibia. And this is now through that range of flexion extension. This is the only real intact tendon that is left. And you can see the amount of excursion that it has from a flexion to extension. It really lengthens a lot. We do the surgery under tunique, holding it very high, which sometimes is a problem in the sense that the tunique anchors the muscle, but then it's a balance between having a better operating field and doing that. So if you have trouble, you can of course always release that tunique. Post-operatively, it's important that patients should have good pain relief, and they should have active physiotherapy with stimulation as required for at least 10 to 15 days in hospital as an inpatient. CPM, I'm not a big believer in it. It doesn't do anything. The issue is with maintaining the range and improving the muscle strength. So that requires active therapy. All our patients that we've done have got back 90 degrees flexion with a minimum to no lag, and functionally all of them are doing well in terms of normal day-to-day life. There are complications that happen. Most of them relate to the wound edges, effusion, and a loss of motion. So because we are not suturing back the parapatellar incisions and just doing a subcutaneous, so that there is a large area which is open and that can collect fluid. This guy had 2 aspirations. We used a compression bandage, a little bit of rest after the first 10 days or so, and continued mobilization. And he had a full range of motion at the end of it. Also, this guy who had a lot of adhesions over here because this fracture was in the distal femur and we had to go through his original incision. So this was what we did initially. He had an effusion, some darkening of his skin. That was the amount of flexion we had got. But he had trouble from the skin edges, ultimately broke down in the center. But through all of this, we kept him moving. So whatever problem occurs with the skin, later on we will deal with it, but whatever movement has been gained, that has to be kept. So at the end, once everything else was settled, we opened it up again and excised these bad edges, sutured it, and it all healed uneventfully. That is the range of motion he had, from only about 10 degrees range of motion. And this for most patients is good, because they're able to deal with normal life on a regular basis. That's him finally at the end. We didn't do anything for he was already healed. His issue was only knee stiffness. So though he's in a little bit of varus, that's not something that we were addressing. So in conclusion, knee stiffness is a significant disability. We should always try and prevent it by doing good therapy when we do fixators and we put on lengthening frames and all that. But if it's not due to a fracture or intra-articular adhesions, many a time they will improve. I give them, as I said, up to a year for it to improve. If not, then you can think about a Thompson's or a Juday's procedure, depending on what exactly is the need. And even if you have problems relating to effusion, skin incisions, etc., the most important thing is to keep them moving while you are still dealing with the problem. How often, Vasu,
Yeah.
do you have this issue of, rather, how often do you need to deal with knee stiffness? For me, it's a pretty common thing, not my patients, but patients who come from outside.
Yeah, we used to have the problem.
You are muted.
No, it's there. Can you hear me now?
You're still muted.
No, sir, we can hear.
Oh, you can hear?
I can hear him.
Okay.
I can hear him.
Sorry.
Yeah, that's a clinical situation. We face it. I do the same thing like you have explained. Sometimes they may have an intra-articular fracture. So what I do now, I do an intra-articular osteotomy and refix it with a strong fixation. Along with that, I do a corticosplasty. And sometimes I put a fixator on that. Fixator with the 2 pins in the proximal femur, 2 or 3 pins in distal tibia, and with a hinge, appropriate hinges, and mobilize it. Along with the
keep it in flexion, then keep it in extension, keep it in flexion. Okay.
But I keep the pins as high as possible, posterolaterally.
Right.
And maximum 6 weeks.
Hemant?
I mean, I have to say, I haven't done any. One of the things I have done a number of years ago, I stopped using external fixation for the femur completely. I can't remember. And but for some reason, I've never come across and haven't done one. So one of the plans was in future, when I'm in India next, I'll pass through Bombay, and if you have 1 or 2 cases, put it on your list and I'll come and see you how to do it.
So it's actually meaning it's an anatomical dissection basically. It's a surgery that I love because it gives such a gratifying result, and it's really not difficult as long as your anatomical dissection is good. And this really is something that we say that surgeons are your whole experience and your knowledge to a large extent is based on things that you have learned from others to a large extent. Some things you may have developed on your own, but this is this used to be Shane's favorite surgery, and he would pick out that difference, the space between the rectus and the intermedius, and show it, gleefully. And he used to do it through a small incision. Those days, I think there used to be a lot of intramuscular injections.
Yeah.
In the early days.
What is the fibrosis?
Yeah. So those patients, he would just require this much of an incision over the proximal to the proximal pole of the patella. Open that, cut the intermedius, leave just the rectus intact, and those guys would be like moving, So you would do it with glee. And I do the same thing now with my fellows. I show it and then proudly I show it to them. See the space kind of thing.
I mean, one of the things we sometimes do is arthroscopic release from inside.
Yes.
And that gives us about, again, 20-30 degrees. And a lot of our patients, because the way our health system works, that is, we sort of identify them reasonably quickly. And so we haven't had any major issues. Though I have a couple of patients, actually last week, I did a renailing of a non-union of the femur, and he has about 30 to 60 degrees. And I was thinking if I can do some limited release, 10 to 30. So it was about 30-40 degrees flexion. I was thinking that should I just do some kind of release and modified Juday's and to give him 90 degrees. But so luckily we have been, we've been more fortunate.
Yeah. So there is one question from Sumanyu, how to decide when to do Jude and when to do Thompson. So basically that's what I pointed out, that, when it's a more distal kind of thing, distal fracture, intra-articular, there you are more likely to require a Thompson. In both of them, you have to open up the lateral gutters, recreate the lateral gutters and stuff like that. The additional part of Jude, I think, is lifting off the entire muscle flap of the anterior part of the femur. So where you've got large amount of fibrosis or you think it is stuck down there, then you can. But as I showed in one of the pictures I showed you, that I have excised that fibrous tissue over there. So many a time, even without lifting up all of that, just excising this fibrous tissue will give you a good amount of flexion. And as Dr. Peli has pointed out in that illustration and in his book, that it's a stepwise thing, that you do this, do this, do this. Now, if you've got enough flexion, then the matter is over. And this last bit of, manipulation, that tends to give us, so we get to about 90, 100, and then rest of it you do with a little bit of what I call orthopedic persuasion, gentle force sort of thing. Great. So there is no Z lengthening required, I think, in the, it's not a Z lengthening, it's a separate tendon. You can actually see, Sumanyu is asking, is it Z lengthening in coronal plane? It's not, because if you saw those pictures, the tendon of the rectus is sitting way up. I have not done anything. I found that interval and then put a finger in and just run the finger up and down. There's no dissection, no cutting involved. It's a more of a finger dissection, unless some places are adherent. Great. So thank you very much, everybody, for, first of all the people who presented very good presentations, which kind of brought the whole plethora of issues up, and also the learning points that you all have mentioned. Thank you, Hemant, for taking time out, waking up much earlier than is usual. For Vasu and me, it's relatively okay, in the sense it is 10:30. And this time Badri was also supposed to be there, but I think Badri had a lot of trauma call and all that, so he requested if he could take off. And so in the next couple of meetings, either the next one or the one after that, we will request Hemant to do a mentor talk, which, as I've said, is something that the mentor is especially interested in, or he or she feels that it is important for the trainees to know. And the first session we will have, as usual, cases. I'm also going to start opening it out now to other people. I will distribute guidelines in terms of, okay, what the case should contain, and it should have a learning point kind of thing. And we will open this out to other folks also. Usually it has been largely my fellows, because these are people that I can rely on and tell them, okay, we need a case to present. But now we will formally start opening it out to others, and we can spread that message.
Yeah, and there are a lot of my old fellows, and then the trainees, other people. I can, because this will be quite a good learning experience for them as well.
Yeah, I think, that's the idea of this, that one, people should get into the habit of presenting their case, because when you present a case, you have to look at it in more detail. So then when they share it with us, we can give them inputs. Occasionally there are things that we also learn ourselves when we are looking at someone else's case and applying our mind to it. And then this becomes like a store, no? Once we have done it, we put it up, someone else is looking for discussion on that. This is there all the time, and this is one area where industry does not help, and also this is the specialty itself is so individual case based. There are some principles, but within those principles, each case is different, which is not necessarily the case with, say, arthroplasty and stuff. 90% of arthroplasties will follow one. Then in the 10% that are different, there you may need to do, something different. Whereas here, it's a tibial, it's an infected tibial non-union. But there are 20 other factors which are playing in that. So this becomes, I think, a fund of knowledge. Great. So thank you, everybody. And Supriya and Neeraj, we can please stop the streaming. Once we stop the streaming, we'll have a couple of minutes on. Supriya is there? The OrthoTV folks?
Yes, sir.
Okay.